next few minutes, I would like to talk on one of the important drugs in the management of the type 2 diabetes, that is empagliflozin. See, this is the ICMR India study. It shows the poor glycemic and also the lipid control and also the hypertension control across the urban and also the rural India. So you all agree with me that if you see the HbA1c, 64% of the Indian type 2 diabetes, they do not attain the HbA1c target of less than 8%, less than 7%. So you all know that the target of our HbA1c is 6.5, and nearly, I think 70 to 75% of the people, they don't reach this target of 6.5. So that means a lot to be done in all the type 2 diabetic individuals to keep their blood sugars under the normal level, so that you can avoid the long-term complications like your micro and macrovascular complications. And also see the blood pressure. And the blood pressure, our target of the blood pressure is 120 by 80. But unfortunately, most of the people are more than the 140 by 90, nearly 60 to 70% of the population. And if you see the cholesterols and the triglycerides and the LDL cholesterols, it's supposed to be at 55 in most of the high-risk diabetic individuals. Even if you take the 100, so nearly 60 to 67% of the population are more than the 100 of our LDL cholesterol. So this clearly shows that the metabolic syndrome in India is a combination of the diabetes, hypertension, dyslipidemia, and obesity. The control rates are very, very, very poor, and a lot to be done to improve the blood pressure control, blood sugar control, and also the lipids control. This is the cardiovascular risk in newly diagnosed type 2 diabetic patients in India. If you see the results, it's a very good study from Unnikrishnan, Sahai, Panda, Sharma, etc. across the India. It's a pan-India study. Of the newly type 2 diabetes diagnosed patients in India, 40% were classified as the high risk, and nearly 60% were classified as the very high risk. So if you combine the 40 and 60, it is 100%. So 100% of the diabetics in Indian population are either high risk or very high risk, not the medium risk or the more mild risk or the moderate risk. So presence of the diabetes itself is either high risk or very high risk. That is a very, very important take-home point from today's talk. So in conclusion, newly diagnosed Indian type 2 diabetes are at high atherosclerotic cardiovascular risk. Every diabetic is at very high risk of getting atherosclerotic cardiovascular disease unless otherwise contraindicated. And this data support the notion that further extension of the national wide ASCVD, that is atherosclerotic cardiovascular disease risk identification programs. So we have to identify what are all the risks are there in our society, especially your diabetes, your hypertension, your smoking, your obesity, physical inactivity, etc. And prevention strategies. So preventive medicine is very, very essential in all these individuals. Just you change your dietary approach and you change your exercise program. You do some yoga, do some meditation. These plays a major role in control of all these things to reduce the occurrence of the cardiovascular diseases are very much warranted. So the most important take-home point is presence of the diabetes itself is either high risk or the very high risk, and we have to control the risk factors to prevent the cardiovascular disease. See, atherosclerotic cardiovascular disease in patients with the type 2 diabetes affects 1 in 3 patients with the type 2 diabetes worldwide. So every third patient of a diabetes will be having atherosclerotic cardiovascular disease as a worldwide, whereas in India, I think every diabetic patient will have atherosclerotic cardiovascular disease unless otherwise contraindicated or discussed. So the coronary artery disease is a major CVD burden in type 2 diabetes, affecting 1 in 6 patients with type 2 diabetes, 2 in 3 patients with congestive heart failure, 1 in 3 patients with the CKD, etc., etc. So the most important thing is presence of the diabetes. There will be more CAD, more CKD, more heart failure, more CVA, more peripheral vascular disease, more aneurysms, more infections, etc. So the ultimate, we have to keep the diabetes under good control to less than 6.5, less than 7% of HbA1c. See, this is the pharmacological approach to the glycemic treatment standards of the 2025 updated picture. Here, if you see the top line, healthy lifestyle measures, healthy lifestyle behaviors, diabetes self-management education and support, social determinants of the health. So for every diabetics, these are very, very important. What is more important is your lifestyle measures, your education, your medical education, and your self-management. That is your regular blood sugar estimations, regular follow-up to the doctor, etc. These are very important for all the diabetic individuals. And then you decide when the patient is sitting in front of you, you decide whether this diabetic patient is at the risk of atherosclerotic cardiovascular risk, or is he having very high risk to get this atherosclerotic cardiovascular disease, or is the patient is at risk of heart failure, or is at risk of CKD, or weight is very important person in here because the person is very obese, so weight reduction is the important thing, or your glycemic control is the important. So these are the very important. Nowadays we treat the diabetes, not the reduction of the diabetes alone. So you have to see the beyond the diabetes. So you have to check the blood pressure, you have to see the lipids, etc., etc. So the diabetic management nowadays in 2025 is individualized. Suppose if the person is at high risk of your atherosclerotic cardiovascular disease, or very major risk factors are there, you can choose either GLP-1 receptor agonists or SGLT inhibitors as the initial agents of the choice. All these years, what we learned is we have to start with the metformin. After metformin, what you can add that drug, this drug, that. But today, from the day one, if you think that this patient is having atherosclerotic cardiovascular risk high, so definitely you have to give the cardioprotective drugs. The two cardioprotective drugs are either GLP-1 receptor agonists, either parenteral or oral, and then the SGLT2 inhibitor. So these two are very, very important drugs here. See, we are talking of the empagliflozin. That is a part of the SGLT2 inhibitor. Now the SGLT inhibitor is here as the initial agent of the choice. For example, you go to the heart failure. The patient sitting before you is at risk of getting the heart failure. Fine. What are the best drugs to be prescribed for him? Again, SGLT inhibitor is a very, very important drug. Last time also I told you that there are the 4 pillars in the management of the heart failure. One pillar is either ACE inhibitor, ARB or ARNI. The second pillar is the beta blocker. The third pillar is the mineralocorticoid receptor antagonist. And the fourth pillar is SGLT inhibitor, whether the patient is a diabetic or a non-diabetic. That means for every heart failure patient, whether a diabetic or a non-diabetic, you have to prescribe the SGLT inhibitors. Again, here, when that fellow is at risk of heart failure, so there is always a chance of using the SGLT inhibitor as the initial agent of the choice. For example, if the patient is at the CKD, the protein urea is there, urinary albumin creatinine is more, the creatinine is just elevated maybe 1.5 or 2 or 2.5. So simply says that the hemoglobin is 8.5 or the 9. So obviously the ultrasound abdomen shows there is a medical renal disease or cardiorenal differentiation is lost, or the kidneys are enlarged in size or reduced in size. Usually the reduced in size in CKD, etc. So obviously our diagnosis is CKD. So when the fellow with the diabetes and CKD, again the drugs to be used are either GLP-1 receptor agonists or the SGLT inhibitors. So that means that this SGLT inhibitors or your empagliflozin is good for the heart, is good for the kidneys also. For example, the patient is overweight. So his BMI is say 27 or 28. Our height is 165 centimeters and weight is about 90 kgs or 100 kgs. So that means that we have to reduce the weight along with the diabetes also. Again, here the most important drug to be added is either again the GLP-1 receptor agonists, which can reduce the body weight, and also SGLT inhibitors, which can reduce the body weight and also blood pressure and blood sugars, etc. So again, when the fellow is obese, again SGLT inhibitors are the important drugs to be used in the management of the diabetes. Suppose if the patient, your glycemic target is important, the patient, you are not getting the good report, control with the blood sugars in spite of your metformin or your sulfurias or your O-glucose, etc. Again, SGLT inhibitors you can use as a second agent or the third agent or the fourth agent or the fifth agent in the control of your blood sugars. So in a nutshell, when the fellow is at risk of atherosclerotic cardiovascular disease, the heart failure, the CKD, or the weight, or when the patient has multiple OHs, so SGLT inhibitors are the important drugs to be used in all these individuals. So the robust clinical evidences of EMPA in the management of cardio, kidney, metabolic care, CKM. Now the CKM care. For every diabetic, I want CKM care, not the diabetic care. What you mean by the CKM care? Cardiac care, kidney care, and also metabolic care. Metabolic care means not only your carbohydrate metabolism, and also more and more protein and less fats, and more fiber, less salt, more fruits, etc. So here, if you see the 2014 US FDA in type 2 diabetes, so they started empagliflozin as a initial agent or the one drug to be used in the management of the diabetes. And the EMPA-REG outcomes, the 2015 first positive CVOT trials in the SGLT2 inhibitors, EMPA-REG outcome trials. If you see the EMPEROR, we have the two trials here, the reduced and the preserved. Here it can be used in the management of the diabetes without any approval. And in the heart failure preserved ejection fraction. So heart failure is divided into three groups, REF and PEF and mid-range ejection fraction. In the REF, when the EF is less than the 40, and PEF means preserved ejection fraction, when the EF is more than the 50, you can safely use the empagliflozin. And now the EMPA-KIDNEY trial is there. It shows efficacy established in the heterogeneous group of the CKD with or without the type 2 diabetes up to 20 GFR. So nowadays, the empagliflozin or even dapagliflozin as SGLT inhibitors being used by the cardiologist and the nephrologist, both in the diabetics as well as the non-diabetics, because it also having a very, very effective even in the non-diabetics also, because they are not the hypoglycemic agents, they are anti-hyperglycemic agents. So if you use these empagliflozin or any other SGLT inhibitors, they won't cause hypoglycemia because they act peripherally at the level of the kidney only. They won't stimulate your pancreas to release more and more insulin to cause hypoglycemia. These are the different, you have the three SGLT inhibitors in the market. One is the empagliflozin and the dapagliflozin. Canagliflozin was the first SGLT inhibitor entered into the market. But nowadays we are not using the canagliflozin for the fear of peripheral vascular disease and Horner's gangrene. And if you see the heart failure trials, 35% reduction with the empagliflozin and 33% reduction with the canagliflozin and 27% reduction with the dapagliflozin. And the CV deaths with the EMPA, there is about 38% reduction, and the MACE, there is about the 14% reduction in the empagliflozin. So, SGLT inhibitors consistently improve the heart failure outcomes in patients with the type 2 diabetes with or without the heart failure. Again, the heart failure is a very important disease to be treated, because history of the repeated hospitalization is very common in the heart failure population, and the death with the heart failure is also very high, and morbidity of the mortality with the heart failure is very high. So most of the diabetics, we should not invite the heart failure in any of these patients because it causes poor quality of the life. The cardiorenal outcomes in the patient with type 2 diabetes and atherosclerotic cardiovascular disease, the different studies are there. The same thing, the empagliflozin study, canagliflozin studies, etc. So already I told you that the EMPA, this reduction with all these adverse events or the CV death or all-cause mortality is very, very good and much better than compared to the cana and the dapagliflozin. See, this is the 5-year life year gain. The reduction of the mortality with the EMPA in patients with type 2 diabetes and established cardiovascular disease. In patients with type 2 diabetes and atherosclerotic cardiovascular disease, the EMPA-REG outcome studies, they clearly says that overall study population there is 38% risk reduction, and in the Asians, we have the 56% risk reduction. So Asian diabetes is totally different from the Western population. I have told you several times that we are different, totally different from the Western diabetics, and we get about the 56% risk reduction in the empagliflozin when compared to the Caucasians. EMPA improved the achievement of the systolic goal blood pressure in patients with resistant hypertension. So you know that resistant hypertension is very, very common in the CKD population. Whatever amount of the antihypertensives you use, the BP will be always 160 by 100 or 180 by 100, in spite of your calcium channel blockers or your diuretics, loop diuretics and alpha blockers, connective blockers, and also central acting drugs like dopamine. Here, if the creatinine level is not more than the 2.5 or the 3, so there is always a scope for to use the SGLT inhibitors, which can reduce the blood pressure very, very effectively because of its diuretic effect. See the long-term reduction in the insulin requirement with the empagliflozin because it improves your insulin sensitivity. So the new initiation of the insulin, there is about 54% risk reduction. You all know that type 2 diabetes, they need insulin at some time of their life because after the prolonged years of the type 2 diabetes, say 15 years or 20 years or 25 years, they almost behave like the type 1 diabetes. And you all know that the type 1 diabetes, the drug of choice is the insulin. The same thing happens to the 20 or 25 or 30 years of the diabetic life of type 2 diabetes. They need insulin. Unfortunately, in India, we get the type 2 diabetes in the second decade or the third decade. And if lifespan is about 70 plus or 80 plus, he has to live with the diabetes for the next 50 years or the 60 years. If he gets the diabetes, type 2 diabetes at the age of 20 years, I have seen few cases, even at the age of 12 years, 13 years, 14 years, with acanthosis nigricans, skin tags, abdominal adiposity, and high insulin resistance. And if you get the C-peptide levels are very high, if you get the GAT65 antibody, they are the negative. That means even at the age of 12 years or 13 years, these people are having the childhood obesity and the type 2 diabetes. Imagine these people has to live for another 30 years, another 60 to 70 years with the type 2 diabetes. So what will happen after 25 or 30 years of the type 2 diabetes? Whatever the preserved beta cell is there, that beta cell failure will be there, and apoptosis of the beta cells will be there, and the production of the insulin from the existing pancreas will be zero, and they almost behave like the type 1 diabetes. So you have to introduce the insulin in such individuals. And some individuals, they will present as the LADA, that is a type 1.5 type diabetes. So they present like the type 2 diabetes initially, and immediately after 6 months or the 1 year, they almost behave like the type 1 diabetes again. So this empagliflozin can be used even in the type 1 diabetes because it acts at the peripheral level. See the significant reduction about the doses. See, we all know we have to uptitrate the dose of the OHS, and if we add these SGLT inhibitors, we can reduce the dose escalation also. See, the EMPA consistently reduce the risk of the CV death in patients with atherosclerotic cardiovascular disease, single vessel cardiovascular disease, multi-vessel, history of the CABG, and the prior MI. And if you use the empagliflozin, the chances of the CV death will be very, very low in these individuals. That is the reason dapagliflozin or empagliflozin, SGLT inhibitors is a very, very, very powerful drug for the cardiologist. So the post CABG or post MI or the post heart failure, so definitely there is always a scope to use dapagliflozin or empagliflozin. 100 patients the CAD and the type 2 diabetes treated with EMPA in the 3 years. So a lot of the events has reduced. So the place of the combination therapy. So now in India, we use a lot of the combination of the OHS because our people, they don't like the insulin therapy much early. So of course, when the HbA1c is 12 or 14 or 13, so we have to use the insulin definitely. But in some individuals where the HbA1c is somewhere between 8 and 9 or 9 and the 10, still we want to use the multiple OHS. There is always a role for the multiple OHS therapy in them. So these people already on the metformin, they are already on the glimepiride, they are already on the voglibose, and they are already on the sitagliptin or the linagliptin. Then you can also add the dapagliflozin in them. So some of my patients, they are on the 5 OHS, some are on 6 OHS. So still their sugars are under good control. A1C is around 6 or 7. So definitely you can continue even with the 5 or the 6, provided if they don't have any side effects. On the other hand, some people will be very, very, very sensitive to the metformin. Once you start the metformin, they start getting the abdominal pain, nausea, vomiting, loose motions, cramps, etc. Once you start the pioglitazone, they start pedal edema, increased body weight, anemia. Once you start the glimepiride, they just get the hypoglycemic attack. Once you start the voglibose, they have the gastrointestinal side effects. Once you start the gliptins, they will have the nasopharyngitis, and some people they have the abdominal pain, almost resembles like the pancreatitis. See, in such individuals, so we can't use the different OHS in them, and definitely even though their HbA1c is at 7 or 8 or 9, we have to use the insulin only. See, EMPA plus metformin as initial combination is very good, provided the person is obese, provided the person is also having the hypertension or dyslipidemia. See here, the reduction is very good with this combination. One of the best combination is a metformin plus SGLT inhibitors like empagliflozin because it reduces the body weight and also reduces the systolic blood pressure. See the EMPA as added to the metformin, significant reduction in HbA1c, that means your diabetes control, body weight reduction, and systolic blood pressure. What else can read in high risk diabetic individual? That means it's a drug of choice for your metabolic syndrome. EMPA versus glimepiride as add-on to the metformin. So EMPA plus sita versus the DAPA plus sita. This is a very good study because all these years we are very much familiar with your dapagliflozin because the cost factor. Now the EMPA is also available in the next 10 days after down to the line. So this cost of the empagliflozin from 70 rupees or 80 rupees has slashed to about 8 rupees or the 10 rupees. So now you can compare EMPA plus sita or DAPA plus sitagliptin. So if you see the mean change in the glycogen hemoglobin from the baseline to the end of the study, almost equal, or in some cases, EMPA shows much better when compared to the dapagliflozin. So thank you very much for your patient hearing.